Hello, everyone. I am Dr. Alana Lewis from the Circulation COVID team. As part of our Circulation COVID Updates from the Front Lines interview series, today I am joined by Dr. Michelle Albert from the Division of Cardiology at the University of California at San Francisco. Dr. Albert is a professor of medicine at UCSF and director of the Nurture Center for the Study of Adversity and Cardiovascular Disease. She is also the current president of the Association of Black Cardiologists. Dr. Albert, thank you so much for joining us today. It is such an honor to speak with you.
Thank you, Dr. Lewis, for having me.
So today we would like to get your perspective on a number of different issues related to our fight against COVID, and particularly get your expert opinion on some of the concerning trends that we have been observing. As more data has been published specifically within the United States, there has been a new concern that has not been as obviously apparent in other countries. In the US, African American and Hispanic individuals have been shouldering a disproportionate burden of COVID cases and are dying at significantly higher rates compared to other racial groups. As an expert in the field of racial healthcare disparities, I would like to get your perspective on what specific factors you believe are contributing to these disparities that we are observing. What are some of the unique challenges that are faced by communities of color due to COVID-19?
Thank you, Dr. Lewis, for that question. It is a billion-dollar question indeed. Certainly, there are numerous factors. First, African Americans in particular have higher rates of hypertension, chronic medical conditions, including cardiovascular disease, diabetes, and obesity, all factors that appear at this time in the limited studies that we do have to be associated with higher risk of complications and death from COVID-19. Indeed, African Americans have 2 to 3 times higher prevalence of stroke, for example, than whites in the United States. The other factors include segregation. African Americans and Hispanic or Latinx individuals live in communities that are not accessible, generally speaking, to testing sites. The need to take public transportation to work, where exposure risk can escalate. Overcrowding in homes, multi-generational households, where it will be difficult to achieve adequate social distancing. I think fundamentally we have 2 different Americas. One America that supports the activities and rights of advantaged socioeconomic status individuals, and is patterned by the color of one's skin. So discrimination and segregation are part and parcel of this. Also, there are issues related to socioeconomics, including unemployment. The unemployment rates of Blacks tend to be 2 times higher than that of whites and Asians in this country. Access to care is another issue. The fear of going to a hospital, as you know, Dr. Lewis, has been a big issue for all communities. And certainly one might imagine that that might be amplified in African American communities in particular, where historically there is a mistrust of our medical system and mistrust of research. Also, folks are being told to stay at home. So when one develops symptoms, for example, it is unclear whether or not there's presentation in time to actually get adequate care for symptoms. For example, in New York, which has been undergoing a horrible surge, the you couldn't get admitted to the hospital unless you were short of breath. You couldn't get tested unless you're short of breath. For example, my entire family lives in New York, and these are issues that they face and the community live face. So the issues are multi-layered, but I think the underlying tenet has to do with the long-standing issues related to race and how that patterns education and health outcomes in this country.
Dr. Albert, you've made some excellent points that are so poignant and so true. COVID-19 has really unmasked these underlying issues that were really here all along, and now it's just intensified in this crisis. Moving forward, what are some actionable interventions that can be pursued in order to potentially ameliorate some of the disparities and outcomes that we've been observing in these vulnerable populations? And also, what kinds of things should we be telling our patients?
Right, right. So before I answer your question, I'm happy that you use the word unmasked. As you may know, as president of the Association of Black Cardiologists, I had the wonderful opportunity to organize a webinar that focused on COVID-19 in diverse populations. And we called it At the Heart of the Matter, Unmasking the Invisibility of COVID-19 in Diverse Groups. And in that webinar, we sought to look at the epidemiology, the clinical characteristics, the policy issues related to diverse populations. So I just wanted to put a plug in there for our viewers to take a look at our webinar, where we also infused issues related to biology, related to COVID-19 and race ethnicity. But to get to your question, Alana, about actionable interventions, again, because the factors contributing to the higher complication rates and death rates in Blacks and Hispanic or Latinx individuals, the actionable interventions will also have to be multi-layered. I'd like to think of them in different categories. So the first category in which I'd like to think about it is focusing on epidemiology. One has to collect data by race and other socio-demographic characteristics like geography in order to better understand the patterning of COVID-19. One has to do widespread testing in all communities, make testing accessible, do relentless contact tracing in order to isolate any surges or spikes in the COVID-19, including in Black and Brown populations. From the perspective of the built environment or housing insecurity, there needs to be expansion of housing availability for vulnerable groups, making it easy for to quarantine if one is infected. As I mentioned in your first question, because of crowding and multi-generational households, and actually even in the homeless population, it is difficult to be able to quarantine. So providing housing, perhaps hotels, you've seen hotels have risen to the occasion, and providing empty dorm rooms potentially. From the perspective of economics, there are several things. One is addressing food insecurity across vulnerable groups, especially in the elderly and in low-income individuals. A lot of elderly African Americans are shut in at this time because of one, fear of going outdoors, also losing accessibility to support structures, including emotional support structures that they might have. So providing services, and this may be partnerships between private industry and private sectors to be able to deliver food to the elderly and shut-in. Funding food banks. You've probably seen across the country a rise in folks getting food at food banks. And disproportionately, those individuals are going to be African American and Hispanic or Latinx individuals. So that's an economic side. Another part of the economics will be making sure that individuals get paid sick and quarantine leave in order to decrease transmission or spread of the virus, because many Black and Hispanic and Latinx individuals work in service industry, for example, and these are essential jobs, in addition to the healthcare industry. And so many are going to work. There's also, I believe, an intergenerational component of actionable items as well, where policymakers need to focus on access to free internet. Since we're moved to telehealth, we've moved to virtual classrooms in order to decrease potential disparities related to the ability to be able to access telehealth, to be able to work from home, and also for kids to be able to get the same level of educational access as their white and Asian counterparts. This is I think that's a big concern of mine, because indeed educational disparities, which start very early on in life, then propagate throughout life to unmask, so to speak, further disparities. And then I think finally, expanding healthcare coverage. I recognize that that is a big and maybe not as actionable item, but it should be an actionable item. Other, sort of looking down the road in terms of additional actionable items might include, as we think about therapies and we move toward vaccines, getting a vaccine, hopefully in a year, for COVID-19, ensuring that all populations get vaccinated at the same rates, because there are disparities in vaccination, for example, with the flu vaccine, by race, ethnicity. I would say also encouraging communities of color to donate blood, because a huge, especially right now, especially individuals who've had COVID-19, as you may be aware, there are trials, research trials ongoing, looking at the use of convalescent serum. And that there's a biological underpinning to blood donation based on blood type, et cetera, in addition to the immunology of the virus. So it's going to be important from a biological perspective for Black and brown populations to be an active part of blood donations as well.
You've made some excellent points, Dr. Albert, and it sounds like there are a lot of things that we can do and that we should definitely start working on. The last thing I want to ask, just in the interest of time, kind of along those lines in looking ahead, you're obviously a leader and an innovator in the field of research. What types of suggestions do you have for ongoing investigation in this area, and what type of questions should we be asking? What should be our focus in research moving forward?
Yeah, that is a huge, huge question. And I'm not sure that I totally know the answers to them, but I'll try. I think one upfront thing is actually providing funding to all types of learners to be able to tackle this problem, because obviously we're going to have to put all our heads together. And as you know, American Heart Association is providing COVID-19 funding for rapid track research in this arena. So is the NIH, and so and other entities, including private industry. So I think funding, from a research perspective, throwing a lot of funding at this issue to have our scientific communities come together to work. I think pooling of ongoing NIH cohort studies to understand the experiences, risk, and disease pathogenesis of COVID-19 is also going to be important here. Capitalizing as well on artificial intelligence, machine learning, deep learning, in order to help tackle this problem or upstream issues. I think in terms of specific questions, we need to understand whether or how complications are differential by race, ethnicity, because it might be, for example, as we're beginning to hear about CNS complications and we're beginning to hear about venous thromboembolism, we know already that venous thromboembolism and things like early onset of dementia are more prevalent in African American communities, for example. So these are going to be major things to take a look at. I think we're going to need to elucidate the role of the ACE2 receptor and COVID by race ethnicity. As you know, hypertension is most prevalent in the African diaspora worldwide. This is going to be an important question to understand at a basic science level, as well as at a treatment level for actually all populations. But because, you know, African Americans and Blacks, period, worldwide are more likely to be hypertensive and less controlled in their hypertension, it's going to be important to pay attention to that particular question. I think for younger persons, it is going to be important to pay attention to what might be happening differentially by race, ethnicity in children. Thus far, this pandemic, certainly in terms of the visible complications, has, you know, seemed, quote unquote, to spare children. But we need to understand whether there are issues related to molecular factors or biomarkers or hidden pathogenic effects in children by race ethnicity, because again, we know that there tends to be patterning based on race ethnicity and socioeconomic status. And then I think from a clinical trial perspective, as we rush to figure out therapies for COVID-19, it is going to be important, as it is for all clinical trials, to have individuals of different race and ethnicity and socioeconomic status enrolled in these studies in order to understand and identify if there are any signals that might portend either heightened risk or improvement for drug therapies.
Dr. Albert, I would like to thank you again so much for sharing your expertise and your perspective with all of us today. Thank you for all of the brilliant and innovative work that you do to make a difference in the care of all of our patients.
Thank you, Dr. Lewis, for having me, and it was wonderful talking to you here today.